Greetings again. We're going to talk here about some of the causes of direct hyperbilirubinemia. So we'll just look at the bilirubin metabolism, kind of recap it. I'm not going to go into the differences between physiologic and pathologic jaundice again. I talk about those in the other jaundice talks. I highly recommend that you really get the difference between those two down very, very, very solidly because they are going to be tested on the exam. We will talk about indirect versus direct hyperbilirubinemia. Pretty clear. It's just a matter of looking at the labs, but we'll talk about some of the causes, how to work these up, and then we'll go over some specific causes of direct jaundice. So for clarity's sake, as you probably know, unconjugated bilirubin is the same as indirect bilirubin. Conjugated bilirubin is synonymous with direct bilirubin. Laboratory pathologists may have a different opinion, but for our purposes, for the purposes of most of the medical world, these are used synonymously. So this is your bilirubin pathway. Of course, it starts from red blood cells, from hemoglobin, and gets broken down ultimately to bilirubin, which gets chaperoned to the liver by albumin, converted to conjugated bilirubin, and then leaves through the bile tract and ultimately out the gut. It can also get reabsorbed through the enterohepatic circulation, go back to the liver, or it can get deconjugated at the terminal ileum and subsequently converted into pigment agents that are passed through the feces or through the urine. So a direct hyperbilirubinemia is a hyperbilirubinemia where you have a conjugated bilirubin, more than 20% of your total serum bilirubin, or more than 2 milligrams per deciliter. And there are two different categories of direct hyperbilirubinemia, and this is going to be the first very important point or pearl that you should be aware of. So there are intrahepatic hyperbilirubinemias, direct hyperbilirubinemias, meaning it is occurring in the liver, in the liver tissue itself, or extrahepatic, meaning it's more in the biliary tract, either the really small biliary canaliculi or the larger bile ducts themselves. So intrahepatic versus extrahepatic, and these tend to present differently. So intrahepatic hyperbilirubinemias tend to present in preterm babies. These babies also tend to look really ill on presentation. They may be small for gestational age, and unlike the extrahepatic hyperbilirubinemias, they tend to have some pigment in their stools. So usually when we think of direct hyperbilirubinemias, we usually think, well, don't they have chalky stools? Not all of them. If it's intrahepatic, some bile may be able to get into the GI tract, and so you will have some pigment in the stools. But that's going to stand in contrast to the extrahepatic causes, which are causes that are implicating the biliary tract itself, either the biliary canaliculi or the ducts. So this is going to appear usually in a more well-appearing baby, full term. Actually, that should say no pigment in stools. Shoot, I can't believe I screwed that up. Okay, no pigment in stools. So these are babies with chalky stools. And then they may even have abnormal facies. That's going to be in a very particular syndrome that we'll talk about. So these can be things like biliary atresia, choledochal cyst, Caroli disease, Alagille syndrome, sclerosing cholangitis, inspissated bile, and extrinsic compression. Whereas your intrahepatic causes they tend to be infectious. They can be genetic or metabolic, particularly those like tyrosinemia, fructose intolerance. Also, another big one is hypothyroidism. And then it can also be induced by drugs, or it can be induced by just being on total parenteral nutrition for some time. So these are, again, your causes here. So ill-appearing babies are more likely to have infections or metabolic disorders, whereas well-appearing babies are more likely to have biliary atresia or anomalies of the biliary tree. Not always, but most of the time this is how it is. So your initial workup, all babies with jaundice should get at the very least CBC with reticulocytes. You should get usually a comprehensive metabolic profile. So that's going to be your metabolic profile with all your electrolytes, but it also has your albumin. It's got your liver function tests, bilirubin. So you want to get liver function tests, bilirubin, metabolic profile. From lab to lab, it's ordered up differently, but you want to have those things. You also want to have a Coombs test on those red blood cells. You want to have a thyroid stimulating hormone level. If this is high, then it's indicating that you possibly have a hypothyroidism, and then a PT and PTT. So once you've gotten all that together, if the diagnosis is a direct hyperbilirubinemia, then additional tests can be considered based on the history and physical. So don't just shoot off tests just because the baby has direct hyperbilirubinemia. Take into consideration the history, the physical exam. Does this look like an ill baby that may have hepatitis or an infection, in which case we want to get torch titers and get cultures? Or does this look like a well baby that might have biliary atresia, in which case we want to get a sonogram and possibly send the baby in for HIDA or for biopsy? So really, it depends on how the baby shows up. Some other tests that may be ordered is the urine for reducing sugars, succinyl acetone, serum ferritin. Of course, the serum ferritin you're looking for neonatal hemochromatosis. The reducing sugars, you're looking for galactosemia. Succinyl acetone, you're looking for tyrosinemia. So those are some less commonly tested ones that may show up. Neonatal hepatitis is a hepatic infection that can be transmitted transplacentally. It can also be transmitted via cervical ascent. So this it can be sexually transmitted. It can be during delivery, or it can be postnatally by exposures to blood transfusions or contaminated breast milk. The cause is most often viral. So you can look at all of these different causes. Herpes simplex virus and enterovirus tend to be the most problematic, the most virulent, so to speak. Some of the bacterial causes include toxoplasmosis, syphilis, E. coli, listeria, group E strep, mycobacterium. So these babies appear ill, and early on there's going to be a reluctance to feed. The baby will be lethargic and hypotonic. Typically they'll be vomiting, and the urine will be dark. If you do a physical exam, you'll note hepatosplenomegaly and, of course, jaundice. But the stools are seldom acholic. Remember, that tends to be with your extrahepatic causes. You'll want to differentiate out other causes of direct hyperbilirubinemia, particularly the other intrahepatic causes of direct hyperbilirubinemia. So those things like metabolic causes. And a lot of those metabolic causes are going to be on the newborn screening exam, but a lot of times they take a while. So you can order those urine-reducing sugars, succinyl acetone, etc. And then genetic causes. All ill-appearing babies with direct hyperbilirubinemia should have titers run for the common pathogens of neonatal hepatitis, because that tends to be one of the more common causes of intrahepatic cholestasis. And you should direct your attention towards any history of maternal illnesses that may be documented, because that can give you some clues. Pan culture should also be taken, so you'll get a sample you can culture the blood, culture the urine, culture the cerebrospinal fluid. You want to make sure that you're getting into all those fluids. And then a sample of the urine should be drawn for reducing sugars and for succinyl acetone, as mentioned. The treatment is going to involve antiviral or antibiotic therapy if the cause is identified, and a lot of causes you won't, and so pretty much you'll just be doing supportive care. And supportive care is going to consist of fluids, adequate nutrition, Making sure that you supplement the baby with medium-chain triglycerides, which is going to allow the baby to better get calories, because those triglycerides don't require bile to be absorbed, and then vitamin supplementation. Specific therapy, if you do identify the cause, if it's cytomegalovirus, you're going to give ganciclovir. If it's herpes simplex or varicella zoster virus, you'll give acyclovir. Parvovirus and enterovirus can be treated with IVIG. If it's syphilis, you'll give, of course, penicillin. If it's toxoplasmosis, you'll give a combination of pyrimethamine and sulfadiazine. You should also give leucovorin for that, too, because of the adverse effects of those drugs. If it's tuberculosis, you'll give isoniazid, pyrazinamide, and rifampin. And if it's those gram-negative bacteria or group E strep, you'll give broad-spectrum antibiotics. Ampicillin and gentamicin is really good. Your broad coverage, covering gram-positive, gram-negative anaerobes, and then surgical drainage if necessary. Babies who are born to mothers who have hepatitis B, the chances of them being born with hepatitis B really depends on a lot of factors. So if the mother is E antigen positive and E antibody negative at the time of delivery, remember with your Hep B titers that E antigen is really it shows how virulent, that's a better word. It shows how it shows the mother's, or it shows the person's likelihood of transmitting the disease. So that if the mother is E antigen positive but E antibody positive, there's a very high likelihood of vertical transmission. If the mom has a high level of hepatitis B core antibody, or if the mom has high levels of HBV DNA. Babies who are born to mothers who are hepatitis B surface antigen positive, they should all get hepatitis B immune globulin, and they should, of course, like all other babies, get hepatitis B vaccination within 24 hours of birth. And as a side, you probably know, on the OB side, all mothers should be screened for hepatitis B surface antigen as part of routine prenatal care, regardless of whether they have been exposed or possibly exposed or not. That goes for all women who are pregnant. Okay, biliary atresia. So this is one of your extrahepatic causes. So this is going to be a baby that will have those chalky stools. This is a progressive fibroinflammatory obliteration. Say that 5 times fast. Of the lumen of the biliary tree, there tends to be a slight female preponderance, but for the most part it's pretty equal. The symptoms, these babies tend to be pretty normal on delivery and on discharge, because remember, it takes a while for that biliary tract to really start working. So you usually don't notice these apart from the normal babies early on, but by the first couple weeks of life, these babies will start to develop jaundice, dark urine, and those clay-colored stools. And remember, physiologic jaundice, especially in a term baby or even in a preterm baby, should not be happening 2-3 weeks after birth. So anytime you have jaundice that late, it's going to be abnormal. And then the dark urine and acolic stools tell you you've got an extrahepatic process going on. If this goes on untreated, the baby will ultimately have failure to thrive because it will be malnourished, not getting vitamins that are fat-soluble. They'll also develop symptoms of portal hypertension, ascites, and then it tends to go pretty downhill from there. So these babies need to be treated. If they're not, they tend to die within a year or two. For diagnosis, this is really the problem with biliary atresia. It is a diagnostic conundrum. How you approach this is really just depends on the situation. I don't expect you'll get asked how to diagnose it on the USMLE, but you should have some ideas of what those diagnostic tests will come back as. So like in most obstructive jaundices, you're going to have an elevated ALK-Phos and gamma-glutamyl transferase. Those should be elevated, but your transaminases, like your ALT, AST, those should only be mildly elevated. The best initial step, in my opinion, apart from the labs, which you usually already have, the best initial step, in my opinion, this is just in my opinion, so don't quote me on this for the test, but if I were taking the test right now, this is how I would answer it if I were asked. The best initial diagnostic step, if you suspect biliary atresia, is abdominal sonography. It cannot diagnose biliary atresia, but it can help you rule out some other causes of extrahepatic hyperbilirubinemia, and it can also give you some hints that it may be biliary atresia. And one of those hints is a triangular cord sign. Don't worry about knowing what it looks like, but it's one of those buzzwords that gets thrown out. So this can really give you some clues, and it also, more importantly, can help you rule out things that it's not. So that would be the first way I would approach this apart from labs. If you suspect biliary atresia after that abdominal sonography, you can get a HIDA scan. That's going to show a normal uptake. There's nothing wrong with the liver itself, but there's going to be diminished excretion because there's biliary tract issues. And then a percutaneous liver biopsy can be done as well. That will, I'm not exactly sure how the pathology will look on that, to be honest, but it will show results consistent with biliary atresia. So the best way to diagnose biliary atresia is actually an intraoperative cholangiogram. So if you've done all these things, you've done a lot of things, and you determine that, okay, yeah, this is probably biliary atresia, you're going to refer the baby to a surgeon, and they're going to do an intraoperative cholangiogram. That is really the best test for diagnosing biliary atresia. It's the best test we have. And if the results from the intraoperative cholangiogram are consistent with biliary atresia, then you're going to go ahead during the same operation, without even waking the baby up, you're going to go ahead then and do the Kasai procedure. And the Kasai procedure is a hepatoportoenterostomy, and basically what you're doing is you're taking a little bit of intestine and sewing it up against the liver to try to get as much bile down as you can. So this is a procedure that has best results if it's performed within the first 2 months of life, and so that really underscores the importance of diagnosing biliary atresia as quickly as possible. So when you go from surgical end, if you go in to do this intraoperative cholangiogram, you're going to be all ready to do the Kasai procedure, expecting that it's going to give you a result consistent with biliary atresia. If it doesn't, then you can make the decision from there. Post-operatively, the baby will need nutritional supplementation. This doesn't cure the problem right away. So formula with medium-chain triglycerides is recommended, as well as fat-soluble vitamin supplementation and monitoring. Transplant is the only other treatment choice if the Kasai procedure does not work. But ultimately, transplant is the definitive therapy. So this is the Kasai procedure here. You can see here is a liver with missing bile ducts, and so here's your stomach and your duodenal C-loop and the small intestine. You make the incision, the duodenum here, close to where it becomes jejunum, and you take that intestine and you're going to sew it up against the porta hepatis, and then you take the proximal end here and you make a Roux-en-Y, and so that making a lumen between the portion that's connected to the liver. A choledochal cyst is a cystic lesion or cystic lesions of all or part of the biliary tree. Clinically and laboratory-wise, the findings are going to be similar, if not indistinguishable, from biliary atresia. And so this is why, in my opinion, getting that abdominal sonogram is really the best initial diagnostic step after labs, because if it's choledochal cyst, you want to know that, because that's going to change your approach than if it's biliary atresia. So choledochal cysts can be suspected on the abdominal sonogram, but you really should get an MRI for definitive diagnosis. And then the treatment for choledochal cyst is surgical correction, but of course, because there tends to be liver issues, biliary issues, you want to correct any pre-existing problems that the patient presented with, such as clotting anomalies and or sepsis. Okay, and then Alagille syndrome is an autosomal dominant disorder of the liver, heart, and kidneys. It also affect the eyes and the CNS. Hepatically, it results in a bile duct paucity, and so that really impairs the ability of the hepatocytes to efficiently release conjugated bilirubin and to get that bilirubin out in the bile fast enough. So long term, these patients also tend to suffer from hypercholesterolemia. I'm not sure why. They'll also suffer from chronic liver disease because of the backup of the conjugated bilirubin, and they're also at risk for undernutrition because they're not getting bilirubin into the digestive tract as efficiently, and they're at risk for hepatocellular carcinoma because of the chronic liver disease. The constellation that you're going to see here, and this will be on the test if you get a question on this, you're going to have conjugated hyperbilirubinemia, of course, but then another thing these babies tend to have is a congenital heart defect. Usually it's tetralogy. They also tend to have butterfly vertebrae where the vertebrae don't fuse completely. Then xanthomas, that's from the hypercholesterolemia. And then this characteristic facies, which I would hope if they give you a question on this, they show you a picture because this will help you. So this characteristic facies is a very broad forehead, a very small chin that tends to be pointed forward, and then very deep set eyes and prominent ears. So I think I have a picture. Yeah. So this baby is adorable. You can also see some of those eye defects that I'm going to show you that too. But you can see the prominent ears here, little tiny chin, kind of pointed forward. You can see that little skin crease, very big forehead. I think they're really cute, actually. Yeah, there we go. And then here's a grown woman. So this is that butterfly vertebrae. You can see there's no fusion. And this is called an embryotoxin. And what this is a very common ocular defect that's seen in Alagille syndrome. I don't believe it affects vision, but what this is the parts of the iris that have ventured out and connected to the descent membrane of the cornea. So I think you can kind of see a little bit of that in that first baby. Well, it's hard to without zooming in, but they look like these little lines like that. See, and you can see other ones here. Really blue eyes, you can see them. Probably browner eyes, it might be a little bit more difficult. That's all I have. Nope, it's not. Okay, diagnosis. So this diagnosis is typically made clinically, particularly if there's confirmed cases within the family, like a parent, since it's autosomal dominant. Otherwise, for definitive diagnosis, you can get a chromosomal analysis. You're looking for the JAG1 mutation. The treatment is just symptomatic. So you'll get consultation with multiple subspecialists managing the various complications that come out of this, liver, heart, kidney, eyes. You'll supplement these people with fat-soluble vitamin supplementation, diet high and medium-chain triglycerides and carbs. That's a good source of energy for people who don't have really efficient bile secretion. You can use antihistamines to help with the pruritus, which is invariably going to come. That's going to be the itching. Then frequent monitoring of their lipids. Remember that they're at high risk for hypercholesterolemia. And that, of course, in addition to their congenital heart defects, can be really problematic as far as heart health. So what we tend to give them for lipids, for lipid reduction, is bile acid sequestrants, also because that also has a wanted side effect of helping with the pruritus. So cholestyramine and cholesterol, but you can use other lipid-lowering agents too. And then routine sonographic screening of the liver for hepatocellular carcinoma. They're at much elevated risk.